This is Dr. Raj Chandwaney. I'm presenting this case of a complex right coronary artery chronic total occlusion that was solved with intentional trapliner-induced dissection and re-entry. This case was originally presented back in 2021, but has subsequently been described as the guide extension Carlino technique. I don't have any relevant financial disclosures. This is a 79-year-old gentleman with an extensive history of coronary artery disease that dates back to his coronary artery bypass graft surgery in 1995 with multiple subsequent percutaneous coronary interventions. He was referred to me for a second opinion regarding the management of his coronary artery disease that is associated with daily episodes of angina. Despite efforts to stabilize the patient with maximally tolerated doses of metoprolol, amlodipine, isosorbide, and ranolazine, the patient continues to require sublingual nitroglycerin 2 to 3 times each day. His myocardial perfusion study was remarkable for moderate ischemia in the territory of the right coronary artery. His ejection fraction is normal. His cardiac catheterization revealed an occluded left intramammary artery bypass graft to the left anterior descending coronary artery. When shooting the native coronary artery, one can see that the native left circumflex coronary artery is occluded. He does have these patent stents in his left anterior descending coronary artery. The saphenous vein bypass graft to an obtuse marginal is patent with patent stents throughout that bypass graft. He was noted to have an occluded saphenous vein bypass graft to the right coronary artery, but there's no stump off of the aorta demonstrated, and that's now a flush occlusion. A dual guide catheter angiogram gives us a sense of the right coronary artery chronic total occlusion, which is occluded in its proximal segment. The dual guide catheter angiogram reveals that it's a full-length occlusion of approximately 120 millimeters. There's only distal filling of the right posterolateral artery and a small remnant of the right posterior descending coronary artery during the dual guide catheter angiogram. The origin of the right coronary artery is noted to be anterior. This RAO projection after we advanced a wire shows the 180-degree hairpin turn that was present in the proximal segment of the right coronary artery. Because there was no obvious retrograde connections, I attempted to approach this antegrade initially using a Mongo wire, which is inside of a turnpike spiral microcatheter, which is inside of an 8 French trapliner, which is inside of an 8 French AL guide catheter. I was able to penetrate the proximal cap of the chronic total occlusion with our Mongo wire. I chased that with the turnpike spiral microcatheter, but I could not get past the proximal cap of the chronic total occlusion. Anytime I tried to, that would actually cause the system to disengage and we would lose guide wire position. Therefore, we did transition to a retrograde effort. Here's an RAO projection mapping our septals. We actually attempted to surf through multiple septal collaterals using both Xi'an Black and Fielder XTR guide wires, but all of those efforts were unsuccessful in crossing the collaterals. So ultimately we did have to return back to an antegrade approach. We attempted balloon-assisted microdissection initially, but that was unsuccessful. We then deeply engaged our guide extension until we saw a wedged tracing on our hemodynamic screen, and we carefully but briskly injected 1 to 2 milliliters of contrast with the catheter wedge to intentionally create this spiral dissection around the proximal cap of the chronic total occlusion. I was then able to quickly pull back on our Mongo wire and re-advanced it. It knuckled into that subintimal space and was advanced freely here to the mid-segment of the right coronary artery. I was able to chase that with the turnpike spiral microcatheter. Ultimately, the system was advanced to the distal segment of the vessel where we attempted Stingray re-entry. Initially, we tried stick and swap techniques multiple times, bobsledding to several different locations, but those efforts were unsuccessful. Finally, we were able to perform a stick and drive at this location and achieve re-entry. I trapped out the Stingray device and trapped in an over-the-wire 1.5 millimeter angioplasty balloon. We advanced that across the re-entry point, removed the Estado wire and replaced it with a Xi'an blue workhorse wire, which you can see here freely traveled down that right posterolateral artery, confirming that we were in the true lumen of the vessel. We then performed intravascular ultrasound guided angioplasty and drug-eluting stent placements of the proximal, mid, and distal segments of the vessel, and a very good final angiographic result was achieved. In discussion, guide extension Carlino builds upon techniques originally described by Dr. Mauro Carlino, utilizing contrast-induced injections through microcatheters to facilitate chronic total occlusion percutaneous corneal interventions. If reproducible, the guide extension Carlino technique may add to the list of methods that advanced CTO operators can use to move the proximal cap, such as scratch and go, balloon-assisted subintimal entry, base power knuckle, and the Carlino technique. While utilizing the guide extension Carlino, care must be taken to not inject contrast so forcefully and with so much volume that the dissection would propagate distally to the point that it destroys any possible chances for successful re-entry. Also of concern is that such forceful injection of large amounts of contrast could also cause the dissection to propagate retrograde into the ascending aorta. This is a publication that we ultimately released in 2022, formally describing the guide extension Carlino technique that was utilized in this procedure. In conclusion, guide extension Carlino is a novel technique for advanced CTO operators that involves use of a wedged guide extension catheter to move the proximal cap by intentionally injecting contrast to induce a dissection plane around a CTO with a difficult proximal cap. If reproducible, careful application of this technique may provide an additional option to solve challenging CTO cases. Thank you for your interest in this case.